Okay, we are live.
Okay, just want to remind everyone that this is being recorded and live streamed. Welcome to our meeting. Why don't we start with approving the minutes from our September 13th meeting? Could I have a motion? Okay, so I saw Khaki and a second, Travis. All in favor of accepting the minutes? Want to raise your hand? Thank you. Anyone object? All right, so the minutes are approved.
Oh, Mary, can I just interrupt? Sorry.
Oh, sure.
I was listed as present and I wasn't. I'm glad my presence has that kind of impact, but I wasn't at the last meeting physically.
All right, well, we must have felt you there, Sheila. Okay.
Okay.
We'll,
I must have been sending some really positive vibes, I guess.
That's possible. All right, so with that correction, anything else? Okay, let's vote again. All in favor of accepting the minutes with that correction? Okay, so they're accepted. I do want to mention that we have a guest tonight, Jed Wolkenbright. I hope I'm saying that correctly, from the Conference of Mental Hygiene Directors will do a presentation tonight. So welcome, Jed. Thank you for joining us.
My pleasure.
Thanks. Okay, I guess we can go on to my report. Just wanted to mention that Salimar is officially a member of the CSB now. The legislature approved her membership, so that's great to hear. I don't see her here yet, but I believe she'll be attending tonight. Just wanted to remind everyone that Karen had sent out a training announcement that's due by the end of November. So if you can take a look at that and complete that, it's something very familiar that we've done in previous years. So relatively painless, I think, but something that we're required to do. So
do we get to do it like the governor does? One of us just take it for everybody.
Larry, did you have a comment?
Well, actually, I'm changing my name, but I did. Do we have to watch the whole? I mean, I've watched it twice now, and it's not going to be different. So can we just attest that we watched?
Does anyone more official than I have a?
Larry's annual, so you have to watch it again.
Yeah, now that you
Okay.
told us, you absolutely have to watch it.
Yeah.
Yeah, no, I will. I mean, it's the same thing over and over again. So
Yeah, it is required annually. So if you haven't gotten it somewhere else, we do need you to review it and then attest.
yeah, no, I'll get it. I just wanted to know.
Thanks for asking. That was probably on some other people's minds too. So good. So Suli is here. We just wanted to welcome you. You're an official member at this point. So
Thank you.
thanks for joining us. And this is a particularly good meeting for it to be your first meeting. We'll be hearing more about our role and responsibilities during this meeting. So it'll be a good orientation for a lot of us who haven't heard that information either ever during their time with us, or it's been a long time. So that'll be helpful. We're continuing, the nominating committee is continuing to recruit for the one opening that we have on the board, and we're doing some outreach with law enforcement to see if they have any suggestions for us so that can be represented on our board. So that's where that stands. I think that's all I needed to mention. Frank, did you want to take it from here?
Yeah, I'm now functioning on 2 different computers with Zoom open twice, YouTube open twice, trying to figure all this out, but I wanted you to at least be able to see me. Really, the only main update we have is budget presentation was last week. Went fairly well, not a lot of questions. I do expect all of the OTRs, which were recommended in the county administrator's budget, to remain in the full budget. The legislature, I believe, begins voting meetings in the next week or 2. So time will only tell, but it went relatively smoothly and there weren't a lot of questions. So that usually means things will make it through. And that's really all I had. Want to save as much time for Jed as we can.
Okay, any questions for Frank? Okay, great. Well, I'm glad we have a good chunk of time to hear from Jed. I don't know if Harmony or Frank want to introduce Jed or say anything more about him joining us.
Sure. Jed is, welcome, Jed.
Thank
Jed is an attorney and works for the Conference of Local Mental Hygiene Directors. So he is kind of the go-to expert on mental hygiene law for the DCSs and commissioners across the state. Some of you may remember Jed came and gave a similar presentation a few years back, and it was well received. So we're thankful he's able to join us again tonight. And Jed, I'll turn it over to you.
Well, thank you. I'm going to try to share my screen. Let's see. So, are you okay? So, can you see my screen now? The slides?
Yes, we can. We're seeing your notes too, just so you know. Or the next slide.
Okay.
It's fine as long as you don't have anything you don't want us to see.
No, there's no notes on here. It's just it's all the. Let's see. Okay, so this is coming. Let me see if I can. I don't think I have any notes on here, so I'm just, okay. A technical genius I'm not, so sorry about this. I don't know why this is. Let's try this. Is that better?
Now it went away.
Okay. So let me see if I can get this to work now. So if I can get this to work, I'll be okay.
Jed, I think you just hit, I'm also not a technical genius, so maybe I remember this part. At the top on the left-hand side, I think there's a
Yeah.
button you click that says like slideshow or something. If you hit
Yeah, I
slideshow,
just did that. Are you not getting the full slideshow now, or
We're not seeing anything now, Jed.
you're not seeing anything? Okay, so let me share screen and do this.
There you go.
Okay. Very good.
Good job.
Sorry about that, guys. So what we're going to talk to you tonight about is some things that you as community services board members should at least be aware of. We're going to start with a little bit of the history of mental hygiene, because I think you're going to see there's a lot of circular movement within the field, things that happen. And, you know, it's always good to know what happened in the past. So when it comes up again and some people say, why don't we try this? You know, you can always say, well, we tried that 20 years ago and it didn't work. So a little history is good. And then we'll spend a lot of time on Article 41 of the Mental Hygiene Law, which is the Community Mental Health Act. And that's important, obviously, because that defines your role as community services board members, and also is, you know, really critical in terms of what your duties are, what your powers are. We'll talk about some of those things. Included in that will be a little bit about the charter, and we'll save that till then. Then towards the end, hopefully we'll have some time to talk a little bit about the funding and licensing of mental hygiene programs, because that's critical, because you definitely have a part in that. And then hopefully at the end, we'll have some time to just talk about some recent events and trends, which I think you should be aware of, you know, as important, that are important to people in this field. So let's get started. History-wise, just, I'm not going to go into heavy detail here, but basically the history of mental hygiene. And obviously when I say mental hygiene, I'm talking about mental health, developmental disabilities, and substance use disorders. Started like in the mid 1800s, 1843 to be exact. The first state institution opened. At that point in time, their counties could send people who were called inmates to the institution at the cost of the local government. So a lot of local governments decided that really they didn't want to do that, kept people home, and they usually ended up in either jails or in that time in poorhouses. So, but by 1867, the state got its act together a little bit more. They established a board to begin inspecting. And then in the 1870s, they began licensing both public and private institutions. And by 1890, there were actually 9 of these state hospitals really that were there. And then by that time, we had switched to the point where the state had taken on the full responsibility for providing care for the people in these institutions. In 1912, when we're getting sort of more into modern times, there was a commission established to oversee mental hospitals. 1918 is sort of the beginning of the DD system. There was a state commission on the feeble-minded established, which was to oversee care for people who were essentially, at that time, called mentally retarded. We now call developmentally disabled, and there were 5 special care institutions, the precursors of the developmental centers, which no longer exist either, but which have existed to take care of people who were institutionalized in that system. And then in 1926, that's sort of the beginning of the modern world of community mental health, because there was the establishment of what was known as the Department of Mental Hygiene. It was a single department that oversaw all of the mental hygiene fields. And it was done as part of a constitutional reorganization of the state constitution that year. The commissions were abolished, and everything became under the auspices of those departments, of that department. On the federal side, just so that you're aware, in 1946 is sort of the beginning of mental health that had something to do with communities. Harry Truman signed the National Mental Health Act, which included a significant amount of funding for psychiatric education and research. By 1949, the NIMH, the National Institute of Mental Health, which is still very much in existence, was created. And then 1954 is sort of the beginning of your role, or the precursor of your roles as Community Services Board. At that time, in 1954, the New York State Community Mental Health Services Act was passed, and it encouraged localities to establish community-based mental health programs and to apply for state reimbursement. Remember, up until that time, the only care for people with mental illnesses was basically in these state institutions. And the concept by 1954 was, let's bring people back into the community. And in order to encourage that, there was a system of what was called, and still is called, net deficit funding that was created. And the concept was that the care for people in your communities, or in all communities, would be shared between the state and the local government, the county. Each would be paying for 50% of that care. And it wasn't of all the care. The concept was the provider had to go out and try to fund it either through private insurances or through private pay or fundraising or grants or however else it could get money to pay for as much of the services it provided as it could. And then what was left over, that deficit, was then funded 50% by the state and 50% by the county. And that system is actually still in existence. So the 1950s, we're going to see movements now from people out of the institutions now back into the communities. In 1955, when this all started, there were 93,600 people in state mental hospitals. By 1984, there was a third of that. There were 32,000 people. By 2011, there were like 3,900 today, including the forensics, was maybe about 2,500 or so. So you can see those, almost 93,000 people that used to be in hospitals are now in the communities where, it's not that these people are all, don't need services. It's just that the services are now being offered by communities and, which obviously shows that your role in this whole system is pretty critical. And this just is a graph that obviously shows you, what we're talking about here. And there were a lot of reasons for this. There was one of the main reasons, of course, was the introduction of psychiatric medications. When antipsychotics came into existence in the early 50s, tricyclics also. So we had medications for schizophrenia, for depression. So some of the people who had, really had no way of being treated in the past could now be treated through medication, and that obviously could be done in the communities. And by the 60s, we could also be treating anxieties with benzodiazepines. So medication had a lot to do with it. And it created the whole concept of let's deinstitutionalize people. So we'd send people out of the hospitals into the communities. The problem, of course, was that there wasn't a lot of continuity. It wasn't like today where you have to submit a discharge plan and kind of try to make sure that when somebody's coming out of the hospital, they have someplace to go to. And we're very conscious of that today. There wasn't any of that. There's a real failure to meet the needs of people who were suffering from serious mental illnesses. And that obviously caused an increase in homelessness. It caused an increase in participation in the criminal justice system. And, all those things, which we're seeing again, still seeing today, were actually caused. But these were huge numbers of people who, had perhaps been in an institution for 30 years and all of a sudden they were let back into the community and really didn't have the skills or the supports to be able to handle that. One of the big issues on the federal front in 1963 was President Kennedy's proposal which really started the community mental health center movement on the federal side. The legislation actually provided funding for custodial care and some funding for community mental health services. That actually was extended substantially by 1965 when Medicare and Medicaid came into existence. It was a huge difference because at this point in time, the federal government now was participating in the cost of care for people who could not afford to have insurance or could not afford for their own care. However, there was a concern on the part of the federal legislators that state institutions, with these 30 or 40,000 people in them would all of a sudden be paid for 50% by, federal funds. And they didn't want to allow that. So they included in the Medicaid legislation something called the IMD exclusion, which essentially said that people that were housed in institutes of mental disease, the IMDs, where there were 16 or more beds, would not be entitled to Medicaid at all. And in fact, Medicaid only provided mental health care at that point for people under 21 and people over 65. And indeed, most of the over 65 people were actually covered by Medicare. But again, Medicaid wasn't allowed in the institutions, the state institutions. So there was a big movement of older people from the state institutions into nursing homes where they could receive Medicare funding. Starting here. Okay. So going from there, I missed one here. Yeah, okay. So there was also in the early 80s, sort of an up and down here. It had a very short-lived. Rosalind Carter was very interested in the areas of mental health, and she really pushed President Carter to help pass the Mental Health Systems Act in 1980, which essentially created a lot of linkages between federal, state, and local governments and provided some specific funding for people with serious mental illness and for children who were seriously emotionally disturbed. But that was very short-lived because the next year, in 1981, when the Reagan administration came into being, there was a huge cutback in funding for mental health in particular. Federal support was cut by like 25%. And now we see the beginning of what we still know as the block grants, where the federal government would give states X number of dollars to kind of do with as you will. There are parameters, obviously, but it was sort of a funding, it was a way of saving money, really. It was the concept behind it. And, some states like New York actually did use the money for mental health services. A lot of states didn't. But there was a major cutback. 1977 is a key year because this is really sort of the reorganization of the Department of Mental Hygiene. The concept was that alcoholism and drug abuse were getting short shrift in this big department. Mental health and mental retardation were two different kinds of things. So the concept was we were going to divide the department into three offices, one for mental health, one for mental retardation, and one which was sort of a quasi office. It was called the Office of Alcoholism and Substance Abuse, but it really didn't exist in form. It had two divisions within it, one for alcoholism and one for substance abuse. And if any of you were in the field at the time, it was like neither the twain should meet because, the people who treated alcoholism believed in, one theory, which was basically the AA type of treatment or with not treatment, but, the AA system. And people who treated substance abusers had a very different concept, to the point where they actually served alcohol at the graduation ceremonies for people who were graduating from substance use programs. So it was a very, sort of different world at the time. I'm sorry, this is not, okay. So, and then just to kind of bring the history to a conclusion here, the drug side really came into existence in the 1960s. The 1977 was the establishment of the Office of Alcoholism and Substance Use, which with the two divisions that I was talking about. The current OASAS, where those two divisions came together, was in 1992. They were consolidated into one office, at least legally. It took many years before they actually got consolidated, but they did. And then in 2019, they actually changed the name to the Office of Addiction Services and Supports. And then also OMRDD, the Office of Mental Retardation, became OPWDD in 2010. So the other couple of legal things that you should be aware of is in the 1990s, the legislature was saying, look, you state of New York, you've been closing, you went from 93,000 beds down to, like 5,000 or 6,000 beds at the time, or 3,000 beds. You're saving a lot of money by closing all those beds. Some of that, and you're putting all these people back into the community. Some of that money that you're saving from closing all those hospital beds should be reinvested, given back to the community so we can provide services for the people that you're no longer serving. So there was a lot of, this was in the Mario Cuomo days, there was a lot of negotiating back and forth. I actually worked for the legislature at this time, so it was really interesting. There was a lot of back and forth, but ultimately the New York State Community Mental Health Reinvestment Act was passed, and it mandated that at least a portion of the savings that each year when the state closed beds, a portion of that savings had to be reinvested or funneled into community mental health programs. And that actually has helped us substantially, on the local side. There was also a Supreme Court decision in 1999 by that time, the Americans with Disabilities Act had been passed. And the question was whether or not mostly people who had developmental disabilities, whether it was okay to keep them in institutions any longer. And the Supreme Court said no, that it was a violation of the Americans with Disabilities Act to keep people who had developmental disabilities in inpatient settings if a more appropriate community setting could be available. So we began to see, although it took many years really before the Olmstead and many lawsuits on the part of the federal government before Olmstead really came to fruition. But, the things like the closures of the sheltered workshops and the closures of all the state developmental centers and all of those things were really as a result of this decision that all people who with developmental disabilities should be served in the community, not isolated in institutions. The other big issue is equity, and that was the equity in terms of cost. Prior to 1996, basically, most insurance plans, including Medicare, Medicaid, really handled mental health issues differently than they did physical health issues. So the co-pays, the lifetime benefits, and all those kinds of things for mental health services were generally a lot higher than what they were for physical health services. In 1996, for the beginning of parity, there was just some legislation that said that the dollar caps on lifetime benefits had to be the same. But 2008 was the real parity law that came into being, the Wellstone-Domenici Act, which really basically said that the benefits for mental health and substance use disorders have to really be the same as those for medical and surgical. So the co-pays, the deductibles, the lifetime caps and whatnot have to be the same for the group plans, for Medicaid managed care plans, for the CHIP, and for any plans that apply to Medicaid benchmark plans beginning in 2014. And the Medicaid benchmark plans are the ones that were created under the Affordable Care Act. It was all the plans that are covered under the different, either the state or the federal plans that are required under the federal care. And again, parity simply means that the financial requirements have to be the same. There's now a New York rule, which fairly recently came into being, which basically says that under the new regulations, there has to be a compliance program so that the insurance companies actually can show that they're following the parity laws. So that's kind of critical. And then just the last of the legal things is the Affordable Care Act. It's gone up and down, and there's been some more important things and less important things. But from our perspective, from the mental hygiene side, the community mental health side, what was really critical is the Affordable Care Act initially established, and one of the portions that has stayed in existence is all of these plans that are offered under the ACA have to include a package of essential benefits. And one of the essential benefits, along with emergency room treatment and prescription drugs, one of the benefits is mental health and substance abuse treatment services. So that's sort of baked into the law, and also baked into the law is the fact that they have to follow the parity. So basically, all of the plans under the ACA have to cover mental health and substance abuse in an equal way as to how they cover all of the physical health things. So it's a little bit more history probably than you ever wanted to hear, but I think it's important because I think you'll see it now. Again, we see it coming back several times, but let's move on to the Article 41 stuff, which is our local services section. Article 41 of the 1977 legislation that I talked about, reorganizing the mental hygiene law, really created this section, which I call, this is my wording, it's sort of the constitution of the LGU. It's what governs what you guys all do on the local, in Tompkins County with regard to mental hygiene. So basically Article 41 was set up so that the purpose was obviously to create this joint effort between the state and all the local units, both for planning for what kinds of services are needed and how we're going to meet those services, and also how they're going to be financed. And there's some important definitions because there are differences. The definition of local government under the law is the 57 counties and the city of New York. So the county legislature in your case is really, the local government in Tompkins County. Then there's also an entity called the local governmental unit, which is a subunit of local government that's established in accordance essentially with Article 41. And you're charged basically as the local governmental unit, which is to provide local services. And what local services are is basically all of the mental hygiene services that you provide to people in your community, suffering from any of the mental disabilities. And then you have to have a plan. You're charged by law with every year having a plan, which you have to submit to the state. And the reason you have to submit it to the state is in order to get the state portion of the funding. And you want to submit this plan on an annual basis, which essentially sets forth, all of the services that are going to be provided in your county. There's also a couple other definitions. The LGU, which we talked about, has to have a board. That's the Community Services Board. That's you guys. And it has to have a director who's known as the Director of Community Services. Different counties call it different things. Sometimes it's called the commissioner. Sometimes it's called, by different titles, the head of different departments or something like that. But essentially, there has to be a person who, under the statute, is known as the DCS, the Director of Community Services. And they're different between charter governments and non-charter governments. And the simple difference is charter governments are those governments that have adopted a charter pursuant to the New York State Constitution, and non-charter governments are governments that haven't. And as I said before, the local services plan has to include, when you develop that plan, you're supposed to include some involvement of different people who can give you information. I mean, you're really responsible for putting together the plan, but you should include involvement of consumers, consumer groups, agencies, providers, and get that input in terms of developing the plan. Has to be approved by the state commissioners. It used to have to actually be approved separately. Well, it still has to be approved separately by each of the 3 commissioners of the offices in the Department of Mental Hygiene. We used to have to submit 3 different plans. Now you can submit a single plan that in a system that they all get to see. So that's a little bit more sensible. But it is your comprehensive plan. So, what services do you need? How are you going to provide them? And how are you going to fund them? Essentially, what you're included. It has to be obviously have a budget that you can say how you're going to do it, and you obviously have to do that budget in accordance with the county local government, because as we're going to talk about later, they hold the purse strings. So you have to kind of work together in order to do that. The goals are really, obvious, that you want to be sure all the different population groups are covered. You want to be sure there's sufficient services, that they're coordinated, that they're integrated. They can be integrated with other counties if that makes us, that's legal. And then ultimately that there's continuity. So people moving from one level of care to another level go with a plan. They're not just, let go and say, go find yourself the next level. There should be some sort of a warm handoff or some other way of trying to make sure that there is continuity. And then all of these local plans come together. They're sent to the state, all 58 of them. And then from those plans, the state develops a statewide plan, or at least it's required to do so under the mental hygiene law. We haven't always seen that necessarily be the case, but basically the statewide plan is supposed to be based on an analysis of all of the local plans. And again, I think that's becoming more true today than it has been in the past, and we're seeing more of that. And just a little plug for the conference here, which I'm going to talk about in a second. We on our website, which you guys have access to, all of the local services plans are sort of posted. We try to keep them for the last 3 years or so on our website. So in the members only section, so that they're available to other DCSs. So you can kind of see, sometimes it's interesting to know what counties, specifically counties that are contiguous or in your region, you want to see what they're doing. This kind of gives you something to look at to kind of get some ideas. And then, as I said, you're required to have an LGU because you want state aid, essentially. If you want state aid, you got to have an LGU. You got to follow the law. And the LGU is also required to have a CEO, if you will, known as the Director of Community Services. Now, this is where you get really critical. Your duties as the local governmental unit, and the LGU is both the board and the DCS make up the LGU, and basically you are responsible for reviewing all of the services in your community, not only that are issued by the county necessarily, but also by all of the providers in the community. Because in terms of doing your plan, you have to know what's going on. And the concept is to try not to have, a lot of duplicative services that are wasted, and not have coverage in other areas that are needed. So, your job is to kind of look at it from the more global level, review the services, review local facilities, develop your local services plan. You have to direct it and administer it, and obviously submit it annually to the state. The power with the approval of the local government, and this is where coordination comes into effect, to enter contracts to provide services, establish procedures for execution, make policy, administer and operate the AOT program, identify the plan, and have the powers necessary to do this. Now, this is where it gets a little fuzzy here. And you guys are sort of in the middle, which we're going to talk about in a second. Normally speaking, we talked about charter and non-charter governments. Non-charter governments, the LGUs, the Community Services Board have all of these powers. Oftentimes in charter governments, the charter can provide a different way of doing things, so that in some charter governments, they can, the county executive usually would appoint a commissioner of mental hygiene or mental health who would essentially have some of these powers. And we're going to talk about that in a second here, but I just kind of keep that in the background here, because this is where we're going to get here. In a charter county, the Community Services Board can either be a policymaking board or an advisory board. So some charters decide to not to give any policymaking authority to the CSB. Some counties do. And this is the list of all of the counties that do have charter governments. You see you're in there. And the role of the county, of this Community Services Board under the county, is determined by the charter, whether or not you have authority to make policy. As I state here, charters such as like New York City Charter, for example, vest the policy-making authority in the DCS, who happens in that case to be the executive deputy commissioner of health and mental health. In those cases, the Community Services Board is advisory only. Stay tuned if I can make this work. Why is this? Okay. In Article 41, as I said, it can go either way. So And there was an opinion of the Attorney General which confirmed this. But as I started to tell you before, the New York City Charter says one thing. Just to give you some examples, the Erie County Charter specifically says that the Community Services Board, which they call a Mental Health Advisory Board, only acts at the request of the commissioner. It's totally advisory. Your charter, getting to the good part here, your charter is a little different. Your charter essentially provides that the county administrator appoints the commissioner of mental health services, but and the commissioner is responsible to the CSB for policy making. So it gives you as the CSB some policy making authority, and the Community Mental Health Services Board has all of the policy making powers granted to a community services board in the mental hygiene law. So think back, you have the notes to where I talked about the powers of a community services board a bunch of slides ago. Those powers actually in Tompkins County, based on your charter, reside in the community services board. So that's something, it gives you in terms of an idea of what you're responsible for. Those are what we're, those are the powers and the duties that have devolved on the Community Services Board in your county. Just some other parts of Article 41 that you should be aware of. In counties of less than 100,000 people, the CSB can have either 9 or 15 members. In those counties with more than 100,000 people, there have to be 15 members. And the question often comes up, who should be on the CSB? The statute says, and we hope we can do this, that there should be at least one doctor and one psychologist, or two doctors, and then either 13 or 7 other members, and then all of the members are supposed to be people who have demonstrated some interest in the field. I mean, it doesn't make sense to put people on a policy-making board that have no interest in the area. So it can be people who have been consumers, it can be people who have been providers, it can be people who have been on other organizations. It is up to the appointing authority, the county legislature, to decide the names of the people, but the statute says that this is the way the board should be composed. This is really okay. The question often arises is, can public officials, people on the county legislature, be on the Community Services Board, or vice versa? And the answer is yes. Neither holding a public office doesn't prevent you from being on the CSB, and being on the CSB doesn't prevent you from being a county officer of some other office. The only thing the statute says is that there can't be more than 3 people on the Community Services Board that are employees of the State Department of Mental Hygiene. So people who work for OMH, OASS, or OPWDD, you can't have more than 3 of those, and not each one, of total 3 from all of those departments on the board. But you may simultaneously hold other offices. The terms of the CSB are really 4-year terms, and the statute says that you can't have more than 2 terms consecutively. You can be on the board for 8 years, be off for some period of time and go back on again, but you're not supposed to be on for more than 2 consecutive terms unless the locality provides by local law to do away with that term limit provision. And indeed, in Tompkins County, your charter actually does away with that provision. So there's no term limiting for you guys on the Community Services Board. The thing that you do need to know is that when a new person comes on the board, such as apparently happened tonight, and congratulations, the term actually, even though it's October, the term actually runs the beginning of those 4 years actually runs from the previous January. So the first year of your 4-year term, Sully, will only be really 3 years and 4 months. So 3 months. So, and that, it doesn't, you have to be reappointed again at the end of that period, just so that you're aware of that. It's a good question, and the answer is no. CSB members are not paid. There's no provision in the statute for payment. You can be reimbursed for expenses if you go to a meeting on behalf of the CSB. If you travel to, Albany to meet with legislators or something like that, the expenses can be reimbursed. But really, if you're only meal expenses is only if you're traveling out of the county. But other than that, CSB members are not reimbursed for the board for the meals. There was some issue in this particular case. This goes back to 1981, where the board decided to hold its meetings at a restaurant, and they'd have dinner during that, and then they would say that the cost of renting the restaurant and the meals was something that they wanted to do. And there was a controller's opinion that said, "No, you can't do that. It's if you're having the meeting there, that's fine, but everybody pays for their own dinner." And the question comes up sometimes: how do we remove people from the CSB? And the answer is the local government, the county legislature, can remove either a board member, a CSB board member, or a subcommittee member, but it has to be for cause. There has to be written notice, and there has to be an opportunity to be heard. So there has to be due process, if you will, before you can do it. There have been obviously instances over the years where people have done things that are out of line, committed a crime, for example, and there's been a desire to get rid of them from the board. It's a doable thing, but again, there has to be some good reason. There has to be even then notice and an opportunity to be heard. The statute also requires you as the CSB to have 3 subcommittees. Statute calls them mental health, IDD, and alcoholism. Different counties have different names for them. There's no provision in the statute for that, but nobody's going to give you a hard time if you choose to use different words for the committees. But the whole concept is these are totally advisory. They have no authority they shouldn't even be voting on anything, really, the subcommittees. The concept is, under the statute, is you have people who are involved in the field of mental health, specifically on that subcommittee, and the same on the other 2. And then if a proposal comes up, you as a CSB can ask the subcommittee to review it and to give you kind of background. And hopefully you have people who are really involved in those individual fields who can give you information that helps you make better decisions. But it's still up to the CSB to make the decisions. And again, those people on the subcommittees are appointed by the county legislature. There's 9 members essentially on the DD and the CD, the Alcoholism Committee, and 11 on the Mental Health Committee. And again, obviously, it should be people who know something about the subject. They're there to give you advice, and there's no sense in getting advice from somebody who really doesn't know what it is that they're talking about. Now, the statute under Section 4109 provides for the office, if you will, of the DCS as the CEO of the LGU. Charter governments can provide for that appointment however they want to in the charter. In the non-charter governments, technically the CSB, the Community Services Board, appoints and removes the director. Salaries are actually set by the board, but in charter governments, as I said, can vest the policy making where they want. Obviously, in your charter, it it allows the county legislature to do appointing and then report to you. Who can be a DCS? The statute really only says that the DCS can be either a psychiatrist or a person who meets the standards set by the commissioner. And that's the only thing the statute says. The standard set by the commissioner means in the commissioner's regulations, which we'll talk about in 1 second. The other thing the statute says that is that if the director is not a physician, then any duties of the DCS that require an examination, there's some DCS duties that actually require the DCS to examine a person to determine whether they have a mental illness. That has to be done by a physician, obviously appointed by the DCS. The statute does not require the DCS to live in the county, and it does require that the DCS be a full-time employee. And then what happens essentially is the standards set by the commissioner are set forth in section 102.6 of the regulations. And that gives you a lot more people. And you have these in your handout, so I'm not going to read them all to you. But basically, it includes people who have degrees in the field, psychologists, social workers. It does not allow mental health professionals, and because this regulation predates the concept of a mental health professional. But I will tell you that we fought that issue, and they will be approved by the state. I mean, if you appoint a mental health professional, it can be obviously a nurse, and then it also can be somebody with an MBA or a public health administration degree, hospital administration degree. But clearly, if the county runs a clinical service and you appoint somebody with an administrative degree, then you also must appoint a clinician to obviously run the clinic, because you really can't have somebody with an MBA running a clinic. There also is a 5-year experience portion to this too, that people who are DCSs should have at least 5 years of progressive either clinical or administrative experience in the area, and some experience in a managerial capacity. So what happens actually is when the county decides, any county decides in whatever way it decides to appoint a new DCS, that person has to be approved by what's known as the IOCC. And the IOCC is set up in the mental hygiene law. It's the Intergovernmental Coordinating Committee. And it basically was, the concept was when they set up the 3 different offices of mental health, DD and SUD, the concept was that there are going to be a lot of times when decisions need to be made and they have to be coordinated amongst the 3 offices. And this council was set up to do this. I'll tell you that it never really happened. It never really worked. There was a very short time that the commissioners were actually meeting for a couple of years. But basically the only function that's really logistically left of the IOCC is the approval of DCSs, so that when you appoint a new DCS, the county has to send a letter to the IOCC, which is actually now housed at OASAS, and say, we've appointed so-and-so as our DCS, and they have these particular qualifications and blah, blah, blah. And then you'll get a letter back from the IOCC saying that's fine, or not. Just to highlight some specific duties of the DCS, I've said here that the mental hygiene law 937 is actually the ability to hospitalize people. That requires the physician. The big duty is under 945, which you probably all know about. That's when the DCS gets to order the transport of somebody to a hospital ED, or hopefully in the not too distant future to a crisis stabilization center, so that they can be seen and seen by an appropriate clinician to determine if they need some sort of involuntary treatment. The SAFE Act, that's the SAFE Act really dealing with guns, But the DCS's obligation under the SAFE Act has nothing to do with guns. Actually, it's simply to receive reports from other mental health professionals, determine if the report meets the statutory criteria, and send the report on to the Division of Criminal Justice Services. The AOT program comes under the auspices of the DCS. Section 2209 of the mental hygiene law is to alcohol what Section 945 is to mental health, more or less. And then under the criminal procedure law, it's the DCS who appoints examiners to determine whether people have the legal capacity, whether they're competent to stand trial. A little plug for the conference, if you will, short. Just want you to know that the Conference of Local Mental Hygiene Directors is actually established in statute. It's under 4110 of the mental hygiene law. It includes, by definition, all of the DCSs in the state, all 58 of them. We have some requirements to meet a couple of times a year, to review regulations, to propose rules and regulations. But the basic role of the conference, as we see it, and as it's really been established over many years, is to be really the spokesperson for the counties with the commissioners. We organize meetings on a regular basis where all DCSs have the opportunity to meet directly with either commissioners or at least senior staff at all the different agencies, sometimes with the commissioners, and then to provide you with, this kind of support where we, we'll constantly try to provide, kinds of training or information. Hopefully that's good for, to help DCSs and do their jobs better, to keep them aware of things. But nobody, no matter how good they are, and you guys are good, but no matter how good you are, you can't know everything all the time, and it's good to have somebody providing you information from a higher level. And so one of the biggest issues is that we basically have meetings. We used to have them in person, and we're going to hopefully again in October start having them in person again, where all the DCSs can get together, twice a year. And one of the most, there's a lot of program that goes on. I do this whole thing where I update people on the law, things that have changed in the law, different regulations, cases. But the big issue is that DCSs get to talk to one another, because I think, clearly you'll learn best from people who do your job in other places. So just real quick, you should be aware that OMH programs, mental health programs, are licensed. There's 3 different levels of licensing. One is called the PAR. That's the most comprehensive one. That's like new providers. There's a medium level called Easy PAR, which is like if you're creating a satellite program or something, it's a little less substantial. And then there's administrative actions for not really important things. And the LGU has a major role, especially in the PAR and the Easy PAR, where you actually have to support new projects under the PAR process. They do ask for letters of support under the Easy PAR. So the concept is there's local input required before new programs come into your county. And then on the OASIS side, I'm rushing a little bit because I don't want you guys to totally fall asleep here, but we're almost done. On the OASIS side, it's called, they certify programs, they don't license them. Same deal, really. There's the 3 levels, and the local role in all 3 levels is basically the same. There has to be some prior consultation in the upper levels. So, really, LGUs have a say in new programming in your community. Funding is also important, and they're basically the same. For the state portion of monies that you get, that's the net deficit funding that we were talking about before. Because remember, when Medicaid came into it, 50% is federally funded, and mostly the time, and then the rest is some state and some local. In the OMH side, the county gets every year a state aid letter, which tells you how much state funding you're going to get. From Oasis, you get a state aid funding authorization, basically the same thing. There are some programs that are funded directly from those agencies. Obviously, Medicaid and Medicare, other commercial coverages. The managed care has a big part of this. Obviously, there are some county funds that go into the mix, and then there's some programs that where their participants are self-pay, or there's other fundraising or legislative grants from time to time that help fund them. Medicaid, remember, it was a program that, as I say, is 50% of the, more or less, for New York. It's different for different states. Most of the programs in New York are funded at the 50% level. Some of the extension programs were at a higher rate, but the state used to pay 25% and the county used to pay 25%. A number of years ago, the county participation was capped, and it goes up, but it goes up at a much lower rate than the state. And it's now at about 18%, I think, more or less. And this is just, another way of saying what I did. A couple things just to throw at you, just so that you've heard them, if you haven't already, and you probably have. The concept of that's going on, and there's a lot of new things kind of going on in the field. The whole concept of really integrating mental health and physical health care has now become a really big thing in a lot of different ways. And also recognizing that there's all these things that they call social determinants, like poverty and homelessness and food insecurity and whatnot, that really are part of the problem, so that it's really difficult to provide good mental health treatment for somebody who has severe diabetes and is homeless, because they're probably not going to show up at their appointments. So, the concept is that we're looking to make care more coordinated. We're looking to include in care to some degree, and there's even some federal monies now that are available. Programming that really deals with things like supported housing, so that people who are homeless can be housed in supported housing with wraparound services to help with their, whatever their disability is. Make sure people are signed up for SNAP or other, food programs, to try to do these things and recognize that, homelessness and people that are in the criminal justice system, in many cases, are there because of their disability, and that if we could treat them up front, and it would be preventing, a lot of these problems. The other thing you should really be aware of is the huge impact of managed care and things like value-based care into the system. The care used to be that Medicaid would, a doctor would charge, $100 or whatever for a service. They would submit that bill to Medicaid, and they would be paid whatever Medicaid paid for that service. And it was called, obviously, fee for service. Now we're seeing more and more instances where the state is now contracting with what are called managed care organizations. Managed care organizations have members that they're responsible for providing care for. The state pays them a certain amount of money per person, and they have to provide whatever care, for the most part, whatever care that person needs. The concept is obviously that if they can get these people into preventive services, if they can decrease the number of emergency room visits, they'll be making a lot more money, and likely the person's going to be getting better care. We're treating the whole person, as I said before. So somebody who's got a mental health issue, if you're treating that issue, it may be a lot easier to engage them in the appropriate treatment for their diabetes or their heart disease, or some other physical health problem that they have, which will ultimately reduce Medicaid costs, but also will be better for the person who's receiving the care. And then, the other thing is we're seeing services redesigned. You're going to be seeing, if you're not already, I think you guys are involved in that whole development of the 988 system. That was the concept from the National Suicide hotline level of bringing those into a more structured system throughout the state. It's going to really be expanding services, so people will be calling that one number and will be able to access different kinds of crisis services. The state has, as part of last year's budget, no, this year's budget, created this new entity called the Crisis Stabilization Center. There's going to be separate licensing. Part 600 are the new rules dealing with this. There's going to be a license, a joint license between the Office of Mental Health and OASAS, so that people, and it exists in a few counties now, where police, for example, who pick up somebody on the street who they think has a mental health problem, would be able to take this person to a crisis stabilization center rather than a hospital, and just leave them there, not have to wait around for 6 hours and waste police time sitting in an ER, waiting for somebody to be seen. And also there'd be people on board 24/7 in the crisis stabilization who could hopefully engage people in the right kind of longer term treatment. We're seeing more regionalization of services, so that several counties are starting to work together to provide some services on a more regional level. There's some cost savings obviously involved in that. The whole concept of value-based payments, paying people, paying providers based on the value of the services they're rendered, not just on the fact that they render the service. There was a lot of talk this past year of consolidating OMH and OASAS. That didn't pass, so that probably won't come up again for another year or two, but we'll likely be seeing that again in the near future. And then obviously COVID has set us all on our ears. So those are basically the things that you as the LGU should be aware of. And the reason that you're so important is on the local level, you have all these linkages. I mean, what's going on in the hospitals with primary care, with social services, about peers, you generally have connections with law enforcement, rather than somebody sitting in the state office in Albany trying to make decisions for you, you guys really are in a much better position. So one of our jobs in the conference is try to make sure that the LGU role in the system is observed, because challenges obviously are what make life interesting, but overcoming them, which is hopefully our job, is what makes life meaningful. So I will be happy to take, if you're still awake, any questions that anybody might have. Hopefully that was somewhat helpful.
Yeah, thank you very much, Joe. It's great.
My pleasure.
Any questions from folks? I can't quite see everybody here, but.
Well, I don't have a question so much as just to talk about quickly some of the other things that drive New York's mental health and developmental system, which are crises. In 1972, there was the scandal of Willowbrook and the treatment of inmates there and in other developmental centers. There was the adult home scandal in New York several years ago, where pigeons were flying into and nesting in adult homes for people with major psychiatric diagnoses. And I hope that the scandal of the deaths, of the number of deaths in adult homes, not in adult homes, in nursing homes, will lead to some major change. So one of the ways that New York changes things is because there's a major scandal exposed. I'm sure that's true in other states, but I'm very aware that that's a major resource. I mean, one of the reasons why we got reinvestment money is because people remembered what some of us call the scandal of deinstitutionalization, and we want to make sure that we have money in the communities. So that's one of the ways that that the state responds is when they're embarrassed or held accountable for the mistakes that it's made.
That's true. That's true. And the hope is, I mean, there's a lot more. I mean, you know, some of the problems that have come up from the LGU level, from the local level over the years have really been because of, you know, a lack of resources. I mean, you know, you can only do what you can do. And, you know, today we're suffering, you know, huge workforce shortages, and you're undoubtedly aware of those. You know, the concept of trying to, you know, deal with I mean, part of like the whole concept of Olmsted or Willowbrook or all those was closing those places. I mean, one of the reasons that the state hospitals were even closed going back to the 50s was because, I mean, they were hellholes. I mean, with all due respect, I mean, there were people, you know, would spend 20, 30 or 40 years of their life really vegetating and not really being taken care of properly. So, you know, fortunately, fortunately, from one side, one of the ways of doing away with or preventing some of those scandals is moving people back into the community, because the concept is if you guys in the community are responsible for these people, the care is going to be better. The other part of it, though, on the other hand, is because they're moving all this back into the community, without really providing some of the substantial resources that you probably need in order to really, you know, make, you know, provide for all these people is you know, is also difficult. So, you know, it's a blessing and there's a curse at the same time. But yeah, I mean, it's tough.
You know, thinking about the group that's working on our bylaws, I don't know if Kaki or Sheila, if you had any questions that came up to clarify.
Yeah, I have a couple. Can you point to me where it talks about term limits?
In the charter or in the statute?
Well, actually, in either one.
But the statute was, let's see, I do know the statute. I used to know these sections. The subcommittees.
I mean, is it in the regs somewhere or is it in the statute?
No,
itself?
no,
'Cause I didn't see it anywhere in the statute.
No, it's in the statute. It's under 41. I can get it for you. I can get you both sections. Can you do it? I have my emails on the screen here. Can you see it? Here?
On the,
We can't, we stopped sharing your screen, Jed, so we could see everybody's faces.
Oh, okay, I'm sorry.
If you want to
email-
drop
Yes,
it in
yes.
it's
it's on the slide, I
It's
see
in the
that.
slides here.
yeah,
Can you just shoot me an email and I'll send you the citations? I'd be happy to do that.
okay, I will. The other question I have is that one of our questions have been about whether the 3 members, CSB members of the subcommittees, whether that was a minimum or if that was a maximum. And what you said is that it has to be at least 3.
Right.
And is that an interpretation of it or?
No, that's the statute. I'll send you. Well, everything I had on my
Okay.
slides was statute.
Okay. And one of the discussions that we've had a lot in the last few years has been about potential conflict of interest for employees of funded agencies being either a member of the CSB or of subcommittees. Although encouraging them to attend meetings and involving them in meetings, but not being voting members. Do you have any opinion on that?
Yes. I mean, legally, there's nothing preventing people who are funded or, you know, representatives of organizations that are funded on being on the CSB. And to some extent, you know, there's a value because they bring a point of view that's their point of view that, you know, should certainly be considered. They're important to the process. obviously, if anything, if any action comes up that involves them or their agency, then they have to recuse themselves from that discussion and shouldn't even participate, let alone vote on it. But there's good and bad. I know some counties, I do this for a lot of different counties, and some counties feel very strongly that they, forbid it. There's nothing in the statute that does, but you can by your own bylaws, do that. Other counties feel that as long as you keep it, because remember, all the CSB members are appointed by the local government. So part of the vetting process when people get appointed should be a look at, how you think they're going to vote or be, the kind of job they're going to do. If you think somebody is so blinded, or is going to try to divert funds into their own agency or something like that, then clearly that's not somebody who should even be put on the board in the first place. But on the other hand, providers are an important part of the system. I mean, if we didn't have providers, we wouldn't have a good system. And it's, there's a lot of counties where the county is the provider. And, there's always the feeling by the other not-for-profits in those counties that they're getting short shrifted because, the county is sort of represented on the CSB always. And, why shouldn't they be too? So I think, in those kinds of cases, it's probably more important to have at least one or two representatives from other providers, with the understanding that they can't participate. And, that's just common sense. It's also, legally required that they can't participate in a decision that, if their contract or their organization's contract comes up for review, obviously they should leave the room.
Well, and that's exactly what had come up for us, was agencies who were not represented on a limited number board, feeling, they were getting short shrift when other agencies were.
Well, but life.
We have lots of agencies.
Yeah. I mean,
that's one thing we're not lacking is numbers of agencies.
And maybe the answer to that is that, that the local government, and not saying this other than to say that one of the ways of handling that is to make sure that, at least with regard to the seats that are held by providers, is that there's some movement in it. So, this year it's so-and-so, and 4 years from now, it's going to be somebody else. That's, that's one way to deal with that issue.
Yeah. Thank you.
Okay. Any other questions? All right, good. Well, thank you so much. That was really rich with information. We appreciate it.
Hopefully not too much. Thank you all. It was a pleasure meeting you all. And if anybody has any questions, you have my email on the slides there, in the handout, and I'll be happy to answer any questions.
Okay.
Thank you. That was great.
Thanks, Shed.
No problem.
Thanks.
Take care, everyone. Bye-bye.
Good. All right. So any other comments or thoughts? We're actually a few minutes early here.
Yeah, I would just share, I know Jed, when he was doing research for this and reviewing our charter, he called Harmony with some questions about the BCS and how all that's set up. And technically, we're not in line with the charter right now, and we haven't been since 2015, I think it was, when I came on board, where we were essentially working under a series of resolutions. The first one, the legislature gave that 3-year trial period. And then in December 19th, they made the decision to merge the departments, which will include a charter review. So part of what we have to go through is the charter and establish what we want what we, the collective, we, the county wants the charter to look like in response to the merging of the two departments. So so some of the slides were very clear about the commissioner being the DCS and all of that. And our charter actually says the commissioner will be the DCS. That will obviously have to be adjusted in some form or fashion to account for the merger. So your bylaws review is kind of the first step of that, because some of the things in the bylaws you want to change are also in the charter. Things like term limits, for example, if that's something you want to consider, the charter currently doesn't account for that and would need to either become silent on it or give authority to do it. So there's multiple layers, both the bylaws and the charter, that will need to review and be updated, through this process.
Mhm. Frank, what is the charter review process? Who's taking the lead in that, and what happens?
Yeah, I mean, I think you guys are doing your bylaws now. Christina Moylan, who's listening in tonight, is going to be looking at the Board of Health bylaws with a couple of their members to kind of look at the non-merger type things that we want to address. And then I think probably it might make some sense for those two groups at some point to come together and look at what they want to put in the bylaws and how that would need to be reflected in the charter. I think that would be the first step. Ultimately, the legislature has to do the charter, and it has to go through a public hearing and a referendum and all that good stuff. I think it might have to go through a referendum. So they'll be the final say, but they're certainly going to be looking to all of you to give them some direction on what you'd like to see it say.
Larry?
I just want to quickly point out that even though Frank says we're out of charter, that's technically correct. But everybody knows what we're doing. The state has approved Frank's appointment. The county knows what we're doing. So we're not doing something that nobody else knows about. The reason Frank is the commissioner and Harmony is the DCS is because Frank lacks the clinical experience to be the DCS at this point. But aren't you coming into eligibility to be the DCS?
Yeah, technically, I now have the 5 years of experience and could be appointed. We should point out that Harmony is also technically not a clinically appointed DCS because her license isn't one that they recognize.
Thank you.
So Jed, Dr. Lippert, our Jed, serves as the psychiatrist of record for the department.
Okay. But just to be clear to everybody, especially to Sully, that we're not doing something that nobody else knows about. We all know what's going on.
Yeah, good point.
Sully had her hand up, Mary.
Oh, sorry.
Yeah,
Right
that's
ahead.
okay. Thank you. Can you hear me?
Mhm.
Okay, because I don't have the headset. So this might be a little off topic. I'm not sure. But he mentioned something in regards to like involuntary care. So if someone is struggling with mental health, right, and they're having perhaps an episode or a breakdown and they need assistance and they don't want to get the help, but it's something that is endangering the welfare of people around them. Is there a program or service for that, or is the only option to call the police in Tompkins County?
So the mechanism that's used is the 9.45, what we affectionately call the 945 law. And that actually gives the DCS, Harmony, the authority to have somebody transported to the hospital for evaluation. So it's a transport order if they are a threat to themselves or others. Harmony can also delegate that authority, and we have delegated it to many providers in our community, including most of ours at the clinic. The mechanism that we have outside of law enforcement, we don't have a mechanism for transport really outside of law enforcement. They'll partner with the ambulance system, but ultimately law enforcement is usually involved to some degree because there's the potential somebody refuses to go and might need to be taken against their will. our mobile crisis team is the additional mechanism that we've put in place the last few years to be able to support the community if there is an instance where somebody is a threat to themselves or others, where it's not just law enforcement having to respond, that the potential for our clinicians to be able to respond to support that effort is there, in hopes that we can get folks there not against their will, but voluntarily. Right. But the mechanism is that 945. And right now, law enforcement is a big component of that because it is a transport potentially against somebody's wishes. I don't know if Harmony, you wanna add?
Sorry, and so could anyone make that call? Or would that have to be like a close family member?
No, there are people there are actually people that are identified as reporters in the law that either we have to be there and witness and see it, or it has to be a recognized reporter. I don't know if Harmony, you probably know who those people are better than I do.
Probably won't get it 100% though, but you're right about family. It can be like a sibling, an adult sibling. It could be a parent. It can be a child. Interestingly, it does not have to be an adult, but you have to think about the age of that child. It can also be like a therapist who is working with the person. So they're recognized. It can be a law enforcement officer or a peace officer. So somebody like a college could also be able to be a reporter. So there's a whole list of people who are identified by law who are reporters, and then there are regulations on who can be a designee. So like Frank was saying, there are people who in the county right now, there's a training that I do with people to become well, we just actually updated it annually for all of our staff. And then if somebody wants to be added to the list of a 945, a person who has that capability, they go through a training, and then we give a list of all the people who are active to the hospital and to law enforcement, so they have that available. So like if you asked before ADC, Alcohol and Drug Council, if they said, well, sometimes we have people who have serious mental health problems who come and get services from us, we'd like to have someone who could be a designee. They go through the training in that process. There's also the AOT order that was talked about a little bit. So that's Kendra's law, and that happened after Kendra was actually pushed on a subway tracks in New York City a number of years ago by someone who was seriously mentally ill. So that spurred, like Larry was saying, oftentimes there's a tragedy that spurs on attempts at improving the circumstances for people. And that's where people can be court-ordered into treatment. They actually are evaluated and determine that they could benefit, and they are refusing to follow any sort of treatment that's in the community. But some people will really respond well if a judge says, you know what, you have to get treatment. And it's been shown to be really effective for some people. And there are other people who are going to say, I don't care what a judge tells me to do, right? But there are people who will take their medications and follow through with that. So there are a couple other options available too, so you try and help people get the care that they need.
Thank you, Harmony and Frank.
Great. All right, Stu. We have one more minute here.
Just a point of clarification, Harmony. I remember in the 80s, I guess 90s too, the only one that was able to admit somebody into a facility was the psychiatrist at the hospital or the mental health commissioner. So you're saying now you're training other people to extend that ability to have somebody committed?
No, and I'm glad you brought that up. The 945 is just a transport order. It's a, it means that you're going to be safely transported to the hospital, and then the hospital will go through their entire protocol to make a determination as to whether or not someone should be hospitalized. So just because you get a 945 doesn't mean the person's going to be hospitalized. It just means in our county, it's really nice because if you go by 945, like Jed was describing, sometimes people can sit, other places law enforcement might sit in the waiting room, in the emergency room for like 6 hours or something.
Right.
Our 945s are treated, you get seen in 15 minutes. Like, they know you're coming. We're
Gotcha.
working hard to really improve that communication process.
Mhm.
And the hospital's working a lot on how to improve that whole environment when somebody comes into the hospital. To make it so, they're not sitting there for a really long period of time, maybe next to people who are really, really physically sick, and it could be a very stimulating environment. But that's all that is. To get sent to a hospital, you need 2 psychiatrists to sign off. There's going to be a legal process for that. People's rights are really, as they should be, well protected. That's not something you can just do a training for.
Right. I'm glad you clarified that with the newer training. If you can reduce the 6-hour wait to 15 minutes, that's amazing. That's improvement for our county.
Yeah, and I would also say Jed alluded to the fact that the DCSs and the conference have been advocating at the state level to allow for transport to those stabilization facilities that he was referencing. Because sometimes going to the emergency room and waiting for 6 hours isn't the best place for somebody that's in a crisis to go. And so having the ability to, right now, the law says you have to go to the certified hospital to be evaluated. The hope is the law can be adjusted to go to a hospital or one of these stabilization facilities, of which what the Alcohol and Drug Council is building up on Trip Hammer would fill that role once it's fully operational. So we are building towards having that capacity, along with advocating for the law to be updated so that that's an option.
Right. So that new ADC facility would be able to have that role other than the hospital, would be in addition to the hospital.
For certain.
Yeah, the caveat is that it will not, right now, as it is licensed, it would not work for people who just have a mental health problem. But if you have a co-occurring substance use and mental health problem, it would work. So that's a huge improvement.
Okay.
So, and what Jed was talking about, the regulation, they're just getting ready to, it has not come out yet publicly. They're still reviewing it, is how could you take those programs? Because part of the conference advocacy this year has been, if you have a program like that is appropriate for people with substance use and co-occurring mental health, why couldn't people just with mental health go there too?
Mhm.
Why would you go build another building to
Yep.
do that?
Makes
Right?
sense to
So
me.
that's been some of the big advocacy that he was talking about that they have been doing across all the counties this year. So we'll see where that goes. He's actually reviewing the regulations now to see if the conference will support it, or if they need, or they're going to ask for changes.
Okay, thanks. Yeah, it was nice for him to go down memory lane, all those different policies. That was good.
Oh, well, there was a lot of information tonight. I appreciate all his presentation as well as your questions. Thank you. Good. All right. Can I have a motion to adjourn?
So move.
Stu, and second, Tom, thanks. All in favor? All right. So we'll get together again November 1st, I believe.
Good night, everyone.
Have a good month, everyone. Bye.